Greetings one and all, I'm Kritika Saxena, I'm a clinical psychologist, and today we would be talking about bipolar disorder, which is a type of mood disorder. Now, bipolar can further be divided into three categories, which is bipolar I disorder, bipolar II, a cyclothymic disorder. What are these bipolar disorders? Bipolar disorders act as a bridge between the spectrum of schizophrenia and depressive disorders in terms of symptomology, family history, and genetics. The main disorder here, when we talk about bipolar disorders, is that of a manic episode. A manic episode is characterized by a distinct period of abnormally and persistently elevated, expansive, or irritable mood, and abnormally and persistently increased in a goal-directed activity or energy, lasting at least 1 week or any duration if hospitalization necessary. Further symptoms are, during this period, 3 or more of the following symptoms should be present: inflated self-esteem or grandiosity, inflated ego, decreased need for sleep, more talkative than usual or pressure to keep talking, flight of ideas, which is moving from one idea to another without the completion of one idea wholly, distractibility, which could be coming from the environment, moving from one subject or one object to another, decrease in goal-directed activity, excessive involvement in pleasure activities that have high potential for painful consequences, or what we also like to mention is risk-taking behavior, which is speeding a car, getting in arguments with random strangers, maybe a lot of substance abuse also starts happening. The mood disturbances here in a manic episode is sufficiently severe to cause marked impairment in social or occupational functioning, or sometimes to even necessitate hospitalization, and which is done to prevent harm to self or others. A lot of times an individual going through an episode of mania might turn physically violent, and in that they might end up hurting themselves, not intentionally, but try to hurt others, and in that process might end up hurting themselves also. And sometimes with a manic episode, there are psychotic features also which are present. Psychotic features can look like that of delusions, of hallucinations, of thought process disorders, and like we said, that the main aspect here with mood disorders predominantly is that of the mood. Moving to the next episode, which is the hypomanic episode. There is a distinct period of abnormally and persistently elevated, expansive, or irritable mood, and abnormally and persistently increased activity or energy, lasting at least 4 consecutive days. So in mania, it was 1 week, and here a hypomanic episode, we are talking about 4 consecutive days. The following symptoms can also be seen in a hypomanic episode, which is inflated self-esteem or grandiosity. A decreased need to sleep. An individual might report that they are functioning quite brilliantly and amazingly even on 2 to 3 hours of sleep, or that sleep is a waste of time and they would not like to sleep as much. They may seem more talkative than usual, or it might feel like they have a pressure to keep talking. Again, flight of ideas or subjective experience that thoughts are racing, They might report that one thought is coming after the other and they are blurting that out. There's distractibility also. Increase in goal-directed activity, which is taking up new projects, new tasks, taking up new activities. There is a psychomotor agitation. You'll see in their movements, they're very fast, agile, they want to keep moving. If you ask them to sit, they might be fidgety or squirm in their seat. There is excessive involvement in activities that have a high potential for painful consequences. And again, risk-taking behavior. Now, a hypomanic episode is not severe enough to cause marked impairment or which requires a hospitalization. It might or might not have psychotic features, like I mentioned, such as delusions, hallucinations. Now, to understand that the basic difference between a manic episode and a hypomanic episode is that of the severity. The symptoms remain almost the same. So 1, severity, and 2, the duration. 3, because of the severity of symptoms, the kind of impact or impairment it has on the individual's life. And where 1 might lead to hospitalization or is required hospitalization, the other can also be treated on an OPD basis. Bipolar I, like I had said, is mania with depression. Bipolar II is hypomania with depression. When we say bipolar, we are meaning 2 separate poles. So on one pole we have depression, but on the other we have mania or hypomania. As we had discussed that major depressive episode, the depression, it presents with depressed mood, diminished interest in pleasure, significant weight loss or gain, increase or decrease in appetite, insomnia, hypersomnia, psychomotor agitation or retardation, fatigue, loss of energy, feelings of worthlessness, guilt, diminished ability to think or concentrate, indecisiveness, recurrent thoughts of death, recurrent suicidal ideation. That was the symptom of depression. So in bipolar I, the criteria that we have to meet for at least 1 manic episode with a specifier of anxious distress and mixed features. Now, bipolar I can look like with rapid cycling, at least 4 episodes in 12 months. Now, these 4 episodes can either be of mania or depression, but one has to definitely be of mania. It could also be present with melancholic features, with atypical features, with mood which is congruent to psychotic features, which is mood incongruent to psychotic features, catatonia, peripartum onset, and seasonal pattern. Specifiers for depressive disorders, so like I said that one was the manic episode, the other has to be a depressive episode. The specifiers should be anxious distress, mixed features, with rapid cycling at least 4 episodes in a year, melancholic features and atypical features. Mood congruent with psychotic features or incongruent with psychotic features, catatonia, peripartum onset and seasonal pattern. Let's further understand that what is anxious distress. Its presence of 2 of the following, which is feeling keyed up or tense, feeling unusually restless, having difficulty in concentrating because of worry, fear that something awful might happen, feeling that the individual might lose control of himself or herself. Furthermore, to specify the current severity of the anxious distress, if we say that it's mild, it should meet the previously said 2 symptoms. If it's moderate, then 3 symptoms. It's moderate to severe, 4 to 5 symptoms, and very severe would be 4 or 5 symptoms with motor agitation. Let's understand what are mixed features. At least 3 of the following manic or hypomanic symptoms, which is elevated expansive mood, inflated self-esteem or grandiosity, more talkative than usual or pressure to keep talking, flight of ideas or subjective experience that thoughts are racing, increase in energy or goal-directed activity, increased or excessive involvement in activities with a high potential for pain consequence or risk-taking behavior, decreased need for sleep. Talking about melancholic features, one of the following present during the most severe period of current episode: loss of pleasure in almost all activities, lack of reactivity to usually pleasurable stimuli, 3 or more of the following: distinct quality of depressed mood, despair, morseness, depression that is regularly worse in the morning, early morning awakening, which is getting up much earlier in the morning, marked psychomotor agitation or retardation, significant anorexia or weight loss, excessive or inappropriate guilt. What are atypical features? Atypical features are that of mood reactivity, 2 or more of the following: significant weight gain or increase in appetite, hypersomnia, leaden paralysis, a long-standing pattern of interpersonal rejection sensitivity that results in significant social or occupational impairment. That was for your bipolar 1. For your bipolar 2, the current or past hypomanic episode has to be combined with a current or past major depressive disorder. So like I had mentioned, there has to be one hypomanic episode and one major depressive episode for us to qualify it as a bipolar 2 disorder. Also, there has never been a manic episode, because that would make it bipolar 1. Now specify current most recent episode. It could have been of hypomanic or depressive, with anxious distress, mixed features, psychotic features, catatonia, peripartum onset and seasonal pattern. Now another noteworthy thing here is that specify course. If full criteria for mood episode not currently met, in partial remission, in full remission, which is that the individual has fully come out of the episode or still is coming out of the episode. Specifier for severity, in full criteria for mood episode currently met, which could be, like I had mentioned, 2 symptoms, mild, 3 symptoms, moderate, 4 or more symptoms, severe. That is your bipolar 2 disorder. Coming to a cyclothymic disorder. What does that mean? So, a cyclothymic disorder should be present for at least 2 years, especially in children. Numerous periods with hypomanic and depressive symptoms that do not meet the criteria for bipolar 2. There should be presence of at least half the time, never without symptoms for more than 2 months. The criteria for major depressive, manic or hypomanic episodes have never been met, but symptoms have been present. To understand here the differentiation, when we say that we meet the criteria for the diagnosis, we are looking at the number of symptoms, the severity of symptoms and the duration and course of those symptoms. When it is not meeting that severity or that duration, but the symptoms are still present over a period of 2 years, that is called a cyclothymic disorder. Other specified bipolar and related disorders are short duration hypomanic episodes, which could be of 2 to 3 days, and along with major depressive episodes. Hypomanic episodes with insufficient symptoms and major depressive episodes. Hypomanic episodes without prior major depressive episodes. Short duration cyclothymia, which could be less than 24 hours, where again symptoms both of depression and hypomania were seen, but they were not meeting the criteria fully. Now coming to a very key point, that whenever we are taking history from the client, what are the points to remember? Certain questions that you can ask them. How is your mood most of the times during the day? Since how long have you been feeling low or unable to do things? Do you get equal amount of pleasure from the activities that you previously or earlier used to enjoy? How is your energy level? Do you feel tired easily? Are you able to concentrate on your work, academics, or other activities? What are the kind of thoughts or the type of thoughts that you get about your future? Do you have any thoughts about like a running commentary in your mind? How is your sleep? How is your appetite? Would you signify it as appropriate or not? Have you ever thought about doing self-harm or have been able to do that in the past? How frequently have you had thoughts of self-harm? Have you actively planned the manner in which you would like to harm yourself? Have you talked to anyone about the thoughts that you get? These could be the key pointers to remember while taking history. So you have covered most of the symptoms in this, which is mood, sleep, appetite, the content of thoughts, if there are thoughts of suicide or self-harm present, and also other feelings of either guilt, angry, irritability, sadness, disappointment. Coming to the intervention or the treatment of bipolar disorder. In depression, it is diagnosable and it is a treatable illness. The treatment involves a two-pronged approach, like I had mentioned. One is the psychiatric medication to manage the level of neurotransmitter imbalance. The other is a psychotherapeutic intervention for the various psychological aspects associated with the illness. It has been seen that a lot of approaches or therapies work with managing depression. Some of them are cognitive therapy, behavioral activation therapy, cognitive behavior therapy, and interpersonal psychotherapy. In cognitive therapy, we talk more about thoughts and how there are thought distortions or thought process errors, how to be able to restructure them in order to have a more adaptive or healthy approach. In behavioral activation, we are only focusing upon the behavior. Like mentioned previously, that there is psychomotor retardation, individual might not feel motivated to go through the day or do its activities. So we focus upon these activities and the behavior. We make a chart, we tell the client to be accountable to it and at least carry out the basic requirements of the daily life. Cognitive behavior therapy, as is known, is to be worked both on your thoughts and your behavior and also the feelings that connect that thought and behavior. Interpersonal psychotherapy is important here because that is what helps the individual re-establish communication and interactions with the significant caregivers or peers in the environment. Few more therapies, which are mindfulness based psychotherapy, psychodynamic and psychoanalytic psychotherapy, problem solving therapy, social skills training, family-based supportive therapy. Sometimes, like we had discussed, that because of the socio-cultural environment or the psychosocial factors where family plays an important role, could also be the causal factors of a mental health illness. In this respect, depression. It becomes very eminent to speak to the family, help them understand what the individual is going through and how they can be of help. For your mania, again, the treatment, the first line of treatment is psychiatric medication. In mania, we are talking about a dopamine imbalance on a biological level or a neurotransmitter level. In mania, we also have to understand that the individual is not feeling much connected with the reality or is not in touch with the reality. And that is why therapy might not be the best intervention that can be planned here. Once the individual is on antipsychotics or medication for their mania, whichever episode, manic or hypomanic, and the dopamine levels try to come down, that is when you can talk to that individual in a more therapeutic approach. So for the first line of treatment in a manic or a hypomanic episode is that of pharmacology, which is medication. Let's take a clinical picture, a case here about an individual whom you could possibly see coming to you for a session. Somebody who is experiencing symptoms of mania would come in the room in a very rushed manner with a very swift gait, would possibly themselves look for a spot they want to place themselves and hurriedly go and sit there. You might see them huffing and puffing, trying to breathe loudly or trying to adjust their clothes. They have made a lot of effort in dressing up. You would find that their hair are kempt, if it's a male, beard made, their clothes are tidy and proper. They have a certain way of presenting themselves, which to them it appears appropriate, but from an outside view, from a clinician's view, we can see that all of that is happening in a hurried manner. On being asked how are they feeling, how are they doing, they would say that they're doing brilliantly well, they feel on top of the world, they feel nothing can impact them, and their mood is great. On being asked what has brought them there, usually you would see that clients going through an episode of mania or hypomania are not individuals who would bring themselves to a clinician. It is mostly the family who brings them, because according to them there is nothing wrong with how they're conducting themselves. So on being asked what brings you here, they might respond that, oh, my family member thought that I should be here, I should come and see you, and they are here with me, or that I have been brought here against my wish, I did not want to come but here I am. On further inquiry about their appetite, they would say it's all right, they've been eating the usual or maybe a little more than how much they used to because they're enjoying food. On being asked about sleep, they'll report that I don't feel as sleepy and I feel like I'm working better on less hours of sleep. I feel energetic, and sleep could also be a waste of time, so I'm good with 2 to 3 hours of sleep. I'm feeling highly motivated. I've started a lot of projects at work. I'm getting a lot of ideas, lot of creativity. Creativity is flowing through me, and I'm in a very, very good place. On being asked if they felt angry or irritable, they might say that yes, people constantly are trying to stop them from doing something or the other, or inhibiting them from reaching out for their goal. There could also be, like I had mentioned, some history or background of substance abuse or risk-taking behavior, which is rash driving, taking rash decisions about the business. There could also be overspending of money. They already have a TV, but they've bought another TV. If somebody was to be paid in 500 cash, maybe they've given 1,000 and not asked back for a change. And a family might report that they are feeling distressed because of the individual's current conduct and behavior. On being asked if they feel anything out of the blue or are they okay with the way that they're feeling, they would say that they're feeling wonderful and that they do not require any intervention of any sort. They are on cloud 9 and they would not want anything to be done to bring them down from that cloud 9. A lot of times this individual has to be psychoeducated a little about mania, but in terms of helping them understand how the medication would help them. That on evidence based, what the family has reported, this is how they have been feeling, and what the individual is feeling could also be some amount of stress, and the medication would possibly help them. In a lot of cases, you would also see that the person is unwilling to take medication, and that is when a hospital admission is required. Mania is a disorder that is best treated in an IPD setup, which is an inpatient setup, where there are psychiatric nurses and doctors who monitor their progress, who keep them under observation, and they're making sure that the individual is taking medication. If sometimes medication is refused, then injectables can also be used if the family allows. That is all for the case history and treatment for mania. Thank you very much.